Hello, I'm Liza Benny. I'm quantitative research assistant working mostly on nutrition and growth in young lives. And I'm going to be presenting an overview of the key findings arising from the Young Lives work on child growth and nutrition. Why should we care about child growth and nutrition? According to the Global Nutrition Report in 2015, 1 in 3 people in the world today are malnourished in some form or another, and malnutrition and poor diets constitute the number one driver of the global burden of disease. In 2015, the UN in the Sustainable Development Goals, and specifically Goal 2, aim to end all forms of malnutrition for all people by 2030. And these 5 goals in particular are key to achieving this target, but at least 12 out of the 17 SDGs contain indicators that are highly relevant for nutrition. So targeting nutrition would be central to achieving the SDG agenda. So Young Lives is uniquely placed to contribute to this debate as it has followed children growing up in poverty in 4 different contexts since the turn of the millennium. So Young Lives has collected data on 2 cohorts of children. The older cohort who was born in 1994-1995 and the younger cohort in 2000-2001. We've collected data on their physical growth at multiple age points. So we can see the growth trajectories of these children over time. One of the indicators that we've collected data on is stunting, which is height that is more than 2 standard deviations below the median for children of the same age and gender in the WHO reference population of healthy growing children. And stunting is an indicator of chronic undernutrition, where if stunting happens early in childhood, it has long-term implications for children's later growth and their cognitive performance because of the rapid brain development that's happening early in childhood. And this is supported by Young Lives data. So where children who were stunted in infancy performed worse on cognitive tests and completed lower grades of schooling by age 8. However, what's new that in Young Lives evidence is that because not only does linear growth recovery that happens after the first 1,000 days occur, but it's also associated with improvements in other child outcomes. So for instance, between 21 to 41% of children that we visited in 2002 were stunted at the age of 1. And if you look at the graph, you can see that a significant proportion of the children who were stunted at age 8 were not initially stunted at age 1. And similarly, for those who were not stunted at age 8, a significant proportion of them were initially stunted at age 1. And so between 45% to 61% of children recovered between 1 and 8, where this recovery happened both between age 1 and 5 and ages 5 and 8. And around 8 to 17% of children faltered between ages 1 and 8, where this faltering was mostly concentrated in between ages 1 to 5. There were also significant changes in stunting status in adolescents. Out of the children who were stunted at age 8, more than a third were no longer stunted at age 15. And looking at the differences in schooling achievement and cognitive performance, the gap between those children who recovered between ages 1 and 8 and those who were never stunted was smaller than the gaps between children who were stunted persistently between ages 8 and 15 and those who were never stunted in this age period. Another advantage of Young Lives data has been the wide range of background characteristics that we've collected on these children. So we have data on their characteristics, the characteristics of their caregivers, siblings, households, and their communities. And I'm going to be talking about 2 sets of factors that contribute to children's growth. One at the family level, so mostly focusing on maternal characteristics, and the next at the community level, looking at where children live and how that determines their growth. So among maternal factors, the most important is maternal height, which is an indicator of the genetic height potential that children have, and it's significantly associated with children's growth throughout childhood. So children who are born to taller mothers are less likely to be stunted and also more likely to recover from stunting through childhood. In addition to maternal height, maternal mental health and well-being is also associated with child growth. So risk of maternal mental disorders in the first year of children's life was significantly negatively associated with children's growth at age 1 for all countries, and persistently lower child growth up to age 8 in India and Vietnam. Higher maternal social capital is as well as human capital is also associated with child growth through in infancy and childhood in all countries, where maternal human capital, which is also a proxy for household socioeconomic status, is positively associated with children's nutritional status throughout childhood. Household socioeconomic status is also a significant predictor of children's health and nutrition, as poverty is linked to an increased risk of stunting and lower rates of physical growth and reduced likelihood of growth recovery in all young lives countries. So the graph shows the differences in stunting rates by child location at age 1. Children in rural areas were more likely to be stunted than children in urban areas at age 1, and this continues throughout childhood. So even in contexts where stunting has reduced dramatically, such as Peru, at age 8, children in rural areas in Peru were still significantly more likely to be stunted than urban children. So living in rural areas presents multiple risks for children. Children in rural areas live in households that are primarily dependent on agriculture often, so their household incomes are more vulnerable to shocks that happen at the environmental levels, natural disasters, as well as economic shocks. And their geographic location also affects children's and households' vulnerability to shocks, as well as their access to services. Though access to services have been improving over time in all of these countries, they're still lower in rural areas and among the most disadvantaged populations. And this presents a risk for children achieving healthy growth. And in particular, access to improved sanitation was associated with a reduced risk of stunting at ages 1, 5, and 8 in all countries, but this was not necessarily true for improved water in all countries. Another risk that's presented by location that's not necessarily obvious is the risk that comes from living in urban areas. In India, for example, slum dwelling is very prevalent in urban areas, and the combination of open defecation, high population density, and infectious disease dynamics that are prevalent in slum environments contribute negatively to child growth in these areas. An additional strength of young lives has been the ability to look at trends over time. So comparing the two cohorts at the same age point, so we can look at how growth has changed for children who are growing up 8 years apart in time. So looking at the 8-year-olds over time, stunting has reduced in all countries. This has been due to widespread improvements in socioeconomic circumstances. So all 4 Young Lives countries have enjoyed economic growth on average, but this is not necessarily spread to all parts of the population. However, food security has generally increased over time, and disparities in dietary diversity between socioeconomic groups has also reduced, which has arisen due to improvements in dietary diversity among the poorest groups. This has all contributed to reductions in undernutrition over time. Looking at the other side of the diet story, dietary composition has changed across the cohorts. So younger cohort adolescents are much more likely to consume animal source foods than the older cohort in India, Peru, and Vietnam. And this is reflected in increased prevalence of childhood overweight and obesity, especially in Peru and Vietnam, which is seen in the graph. Um, yeah, so the proportion of children who are overweight or obese, which is defined by having BMI more than one standard deviation above the median of children of the same age and gender in the WHO reference population, has increased over time in India, in Peru and Vietnam. And it has doubled in Vietnam. This is driven mostly by urban children. And this can also be seen in the increase in adult overweight and obesity in India and Peru, which is driven mostly by urban individuals. So, for example, a fifth of urban 22-year-olds in India were likely to be overweight or obese in 2016, and 40% of urban 22-year-olds in Peru were likely to be overweight or obese. Putting all of this together, in terms of policy implications, the key messages coming out of Young Lives has been around the effectiveness of social protection programs. So policies that target both households in order to increase their resources, which can then be invested into children's health and skills, as well as those that aim to increase children's health and nutritional status directly, are both associated with improvements in child growth. So, for example, children who belong to households who participated in the public safety net program in Ethiopia saw improvements in height relative to the reference population, corresponding to around 1 to 3.5 centimeters, compared to children whose households did not participate in the PSNP. Yeah, so programs aimed at reducing food insecurity and undernutrition in India and Peru, such as the midday meal scheme and public distribution system in India, and food assistance programs in Peru, have all been shown to improve child growth outcomes, such as where the midday meal scheme contributed to growth recovery among children whose families were affected by drought, and participation in food assistance programs helped households deal with constraints in food access. However, even though social protection does provide protection from hunger and food insecurity, it often does not do enough to help those who are most vulnerable to shocks. And this is related to the goals and indicators mentioned in SDGs 1 and 10, which aim at ending poverty and reducing inequality. All of these can contribute to reduced child undernutrition in these countries. To recap on the previous messages and highlight the implications these have for policy and the SDGs. So the SDG targets for Goal 2 relate to under 5 nutrition and stunting, but also mention reduction in undernutrition over the life course. So it's important to start investment in child growth and nutrition early, because there is potential for recovery beyond early childhood, as well as the possibility of growth faltering. It's important to sustain investment throughout childhood in order to foster healthy growth over the life course. Investing in the health and growth of adolescent girls is also another aspect that the SDGs focus on. SDG 3 in particular focus on maternal health and well-being. So the potential for growth recovery in adolescence, which is also another period of increased brain function, and the benefits this can have for adolescent girls in terms of improving their growth, as well as the outcomes of the next generation, means that nutritional interventions in adolescents can also pay off in terms of achieving SDG targets. There also may be cultural aspects of this difference that may need to be addressed. So, for example, there's a pro-boy gap in dietary diversity that opens up in adolescence in India, which is related to cultural differences in feeding practices. That needs to be addressed in order to achieve healthy growth for adolescent girls. And finally, discrepancies in access to water and sanitation remain a challenge for the most disadvantaged children in households, so tackling these can also be critical to promoting healthy growth. Thank you.